Okay, hello everyone. We still have a few people joining in, but in the interest of time, we're going to go ahead and get started. Good afternoon and welcome to today's webinar. It's hosted by the Georgia chapter of HFMA. I'm Laurie Hebe with Clear Balance, and I'm also a Georgia HFMA Education Committee volunteer. We have a really great session in store for you guys today with David Ralston of Jackson Hospital. He's crossing the virtual state border from Alabama to share his organization's progress with digital patient engagement. Before we get started, I wanted to give a quick plug for professional certification. If you go online to the Georgia HFMA website, you'll see that the CPAR, the Certified Patient Account Representative, course materials and testing are now available for purchase. You can do that through the website, and the materials and testing will be available until November 30th, and testing concludes December 31st. Before we get started, I just want to go over a couple of housekeeping items. All of the phone lines are on mute to avoid interruptions during the broadcast. If you have questions during the presentation, please go ahead and use the question box at any time, and I'll coordinate with Noel and David for their answers at the end of the presentation. I have in the chat box, and I'm going to activate this now. You'll see here in the chat box, I've included the link to download the presentation. The link is going to take you to the Georgia HFMA website, and I've given you the navigation from the top menu on how to get the presentation. We'll also be posting the recording of today's session in that location as well. Everyone on today's call is eligible to receive continuing education credits. Be on the lookout. I'll be sending this form in email. It'll come from my email, lauriehebe at clearbalance.org, and you'll be able to use the form to self-submit for your credit on the HFMA website under the membership info tab. Now it's my pleasure to introduce our speakers, David Ralston and Noel Felipe. David is Assistant Vice President of Revenue Cycle Management at Jackson Hospital in Montgomery. He's been involved in healthcare revenue cycle for 25 years with experience on both the provider and vendor side. David is known for his success implementing solutions, problem solving, and operational process improvement. David has received recognition as a healthcare revenue cycle operations executive in 2016 and 2017, and has also been part of a revenue cycle team to win HFMA's Hospital Map Award. Noel is Senior Vice President of Revenue Cycle Practice Leader at MedAssist. He also has more than 25 years of healthcare experience in accounts receivable management. Noel has a proven track record of developing progressive client-based solutions and building strong cross-functional teams to implement those solutions and maximize client results. Noel is active with both HFMA and AHAM, and he's served 2 terms as president of the Florida chapter of HFMA and was appointed to HFMA's National Advisory Council for Revenue Cycle. So Noel and David, we're ready to begin.
All right, thank you very much, Lori. I appreciate the introductions. Today we're going to go ahead and kick off the webinar for digital patient engagement. Our agenda is kind of a loose agenda. We'll go over the Jackson Hospital overview. We'll look at our partnership, evolving landscapes, the digital solution itself, our experience, and then we'll end up with any questions. So Jackson Hospital origins go back to about 1894 when it was actually called Watkins Infirmary and received its first patients at the hospital's present location. In 1946, Jackson Hospital opened with 37 patient beds and 5 attending physicians. Today, we have 344 licensed beds, and Jackson is a community not-for-profit hospital, and we serve Montgomery, Alabama's river region. Some of our comprehensive health services that we provide is cardiac care, cancer treatment, neurosciences, orthopedics, and women's and children's health. And we do, of course, have a 24-hour emergency services. Jackson is actually ranked among the largest hospitals in Alabama, and it's actually widely recognized for providing excellent care. Even with our leading edge technology and facilities, we remain really true to our mission, and we want to make sure that we provide superior personal health and a safe and compassionate environment. Our case mix is very heavily weighted towards Medicare and Medicaid. They actually are combined over 2/3 of our payer mix. So our process, I actually got here in August, the very 1st of August of last year. When I first got here, the CFO told me that he would support me to make any changes that were needed to improve our financial well-being. We actually referred to this as change or die. And some of you have heard me use that term before. Because if we didn't make the necessary moves that we needed, we really weren't going to be able to survive. We're approximately 15 years behind in our technology and process, and we had to move our collection performance significantly and reduce our overall costs doing it. So we created a task force and reviewed every area of the revenue cycle and identified people and process and technologies that needed to be enhanced or replaced. We then prioritized them and looked at an order of ease to implement and looked at how the implementation was actually going to impact the value of the organization. So when I got started, we were not performing to our expectations based on the MAP standards, which I've used in the past. And we just weren't making ends meet with how we needed to be using those KPIs. We have a challenging socioeconomic makeup here of our patient population, and we had to figure out how to better engage the patient and improve their financial experience. Our internal self-pay process was inefficient. We didn't have the correct tools, and we did not have a methodology that was going to work well. We were able to get a service center out of our relationship that we did through our process in making these changes. And we were able to redeploy 3 staff to focus on some higher value revenue functions like authorizations, financial counseling, and processes that would also improve cash. So I went to the board and told them that we needed to really modernize our collection efforts. I told them that basically the traditional methods for outreach of calls and letters were really a thing of the past and not as effective as text and email. We were looking at about 15% of our net patient revenue is now patient responsibility. So our goal was to actually make a paradigm shift, not just make a change, but really shift in how we work our business. And it was determined that partnering with MedAssist would provide that shift and help bring self-pay process into the 21st century. The next thing we did was actually we informed the community. We placed posters in common areas in the hospital, and so the community would see that we're embarking on this journey and really, asking them for their support. A little bit of information about our area that was pertinent to us when we were making these changes. The average credit score is about 550. There's a low service environment in the community for healthcare. Engagement had been traditionally low. What we found is, even me, I've moved, 4 times in the last 10 years, and my address, continues to change, and those traditional methods just weren't working. We've had a change in the overall population. It moves us into the 21st century with a single process. It actually was going to make us more relevant in the community. The perception of being more cutting edge within the community and how we're reaching out to our population. Some additional stats about Montgomery: the median salary is about $27,458. The renters population is about 36% of the population rents, and the average rent is $827. So you're not talking a whole lot for additional expenses. The average healthcare spend in our area is about $3,852. Our federal poverty level is it's $24,257, and 22.1% of our population is actually below poverty. So, with Medicaid, that's a significant piece of our population, and we really needed to make the change with those that were able to actually make a payment. So healthcare cost shift. So really now more than ever, it's critical to have an effective self-pay process. I'm sure most of you are aware that patient out-of-pocket expenses have increased about 14% just between the years of 2017 and 2018. But going back every year for the last 10 to 15 years, this trend has continually increased to the point where a patient is actually considered the third largest payer in an organization. And we've just experienced the COVID pandemic, and we need to continue to deploy some additional technologies. So we looked at telehealth, which would eliminate or limit the non-clinical patient-facing interactions, looked at digital point-of-service collections, and as well as contactless registrations. Next slide, please. Thank you. So why transform patient collections? As patient financial responsibility has grown, so has the expectation for a smooth and transparent financial experience. It's really one that allows them to manage their healthcare costs the same way they would conduct their personal business in their normal lives. Using a seamless web-enabled service on personal devices like smartphones and tablets really seem to be the way to go and make that transformation. As noted in a recent Deloitte study, about 60% of healthcare consumers want their experience to mirror that of retail. So what does seamless really mean? Like for us, when you go onto Amazon, you shop for literally anything you're looking for. You're only having to go to one site to purchase what you need. With the ability to compare products, prices, and pick what you need and pay for it all in one seamless session, that was kind of the goal of Jackson Hospital and how we're going to be providing services to our patients. We're really looking for that one-stop shop where they can do everything. Something else to think about is the amount of robocalls and telemarketing calls that people are receiving. It's really impacting collection calls because if you don't know who it is, you're not going to answer. So over the last month or so, they say that it's estimated that about 3 billion robocalls are launched in the U.S., and that's an average of 9 per day per person. And according to, there's actually something called the robocallindex.com, 37% of those were actually scams. So I don't know about you all, but if I really don't know who's calling my cell phone, I tend not to answer it, but I will answer text and look at text. Just seems to be the easier way to manage the business. So HFMA actually did a national survey on their website about managing and driving cash collections, and the cost to collect is at the top of everyone's mind here with 62% of the respondents. Actually, frankly, I'm really not surprised. It's time for some type of transformative change when it comes to patient cash collections, and that's how we chose to approach it. We completely we're going to change the way we're going about cash collections. We're able to reduce the number of vendors, which led to a reduced cost to collect. We had a completely revised our patient statements. For those that chose to receive a patient statement, they were getting something that was a completely different look than they had ever seen in the past. Also, we're going to increase the number of contact points by deploying the email and text communication, and we're able to provide our patients with a seamless digital self-service capabilities that we felt be more effective. So now we're actually going to take a poll here. And Lori, do you want to kick this off?
Yes, I will. So you all should see the poll in front of you, this digital engagement poll. And if you'll take a minute to answer the question, and then David and Noel, I'll let you kind of comment, and we'll give it another few seconds, and then I will end the polling for you.
Hey, so this is Noel. I just wanted to make a quick point here that at the end of the session today, we hope that we'll have enough time for questions. But if we run tight on time, Lori and the HFMA folks from Georgia will provide us with your questions, name of the attendees, and we will follow up with you and answer any questions that we don't get to. So about 42%, 43% have answered. Let's give it a couple more minutes if we can finish the polling. It looks like we're slowing down a little bit.
Yeah.
Let's just give it another
See if we can reach
10 seconds,
50%.
Lori. We're almost there. We need 4 more to get to 50%, guys. Well, it doesn't look like we're making it, Lori, so let's go ahead and end the polling. David, do you want to cover some comments on these results?
Yeah. I guess the first thing, if you've not yet considered moving to a digital engagement, think of it as simplifying your patient experience. So I see that 14% of you are considering it. So I definitely think that's a good opportunity. If you're interested, this is probably a good call to action, and 43% of you seem to be interested in it. This is a great time to really do something like this amidst COVID as well, for patient engagement. And for use for currently use a digital format for collecting patients payment only 43%. You know, if you're considering to move forward, you know, we actually have some additional information that'll help you really think about what your next step should be. So I'll be going into a little bit deeper there. So thank you.
Okay, Lori, I don't know how to eliminate that. I guess we can just close it here. Good. All right.
Yep.
Back to you, Dave.
Thanks. So this slide, patients are seeking to communicate and pay their bills through secure modern technology or modern communication channels. Our patients are actually able to self-serve. Using our digital patient engagement site, it actually provides a very transparent patient experience. I do have to stress something. This is not an app. This is actually a full secured website. It requires, you know, dual authentication to be able to access your information. It allows the patient to manage their accounts by using a device that they prefer when it's convenient for them to do so. And it's really important, this piece, it's actually completely Jackson branded. So they have no idea that we're actually outside of the Jackson format with their complete visual of this. So it's really impressive. Next slide. So while our primary goal is to collect as much cash as possible, not every patient interaction has to be related to making a payment. This also helped us when we were moving our service center away with the additional support of MedAssist. You know, there's things that patients can do that they need assistance with, but now they don't have to even make a phone call. So they can view their patient-friendly statement based on the HFMA guidelines. They can actually add additional insurance information. If they need to add an attorney or bankruptcy information, they can do that as well. They can also ask a question about their bill and we'll respond to that. You can actually upload and send additional documentation if that is needed. And then you can also apply for financial assistance. And it's nice to be able to do this all in one seamless session, so it's very convenient for the patient.
Thank you, David. And thank you, everyone, for joining today. I pray that all of you are safe and your families have been safe through this very, very challenging time that we've had. This is Noel Felipe, and I will be covering the next 11 slides. I'll be covering a lot of analytic data that we've collected from our engagement at Jackson Hospital. We'll talk about how patients are engaging, when they're accessing the site, what actions they're taking when they get there. But first, let's review some of the highlights that we think really set this tool or capability apart. Number one, it's a responsive website, as David mentioned. That means that it can be viewed on a tablet, on a desktop, or on a handheld device. We built this as a website because we really did not want to have to build a tool that would require patients to download an app. And that was really around trying to limit friction. Just having to download another app, create another login, and having to remember another set of passwords was just something that we felt was something that we wanted to avoid. We wanted to create as frictionless an engagement process as possible. And given that 90% of accounts that we receive at MedAssist have a mobile number, and handheld devices are the way that we as a society today communicate, and how many of us conduct our personal business, our primary communication method are text. We also send emails, and if either of those are not available, then obviously we will communicate via US mail. A very, very, very key function that we wanted to build, and David just covered it on the last slide, was we wanted patients to have the ability to self-serve. That means that if they would otherwise have to call a call center to address any concerns or issues that they would have relative to their account, that they would be able to do that 24/7 in a self-serve environment. And as we move through the presentation and I get into the analytics, I'll show you some very, very interesting statistics about just when patients are engaging and how they're moving along. Our communication strategies are driven by a series of algorithms that constantly fine-tune over 100 proactive and reactive messages that intelligently respond to how patients are behaving. So for instance, if a patient visits the site, they view the payment plan page, or they view the page for financial assistance, and they don't take action on their visit, then we intelligently respond with a message that offers them assistance. You've been to the site, you were not able to complete any functions. Is there something else that we can help you with? Would you like us to call you? Would you like to call us? So a very, very proactive and reactive set of strategies that reacts to how our patients are engaging with the site or not. Payment plans are all tailored to individual patient characteristics. These include propensity to pay scores, patient age, account types, and also prior payment behaviors. All of that is viewed and analyzed by our analytics engine to drive these individual payment plan offers. And lastly, on the next slide, I'm going to cover how we use treatment and diagnostic data to identify potential third-party coverages that may have gone undetected after the patient was discharged. So, like a lot of you on this call, or like some of you on this call, I started my career as a self-pay collector a very long time ago. And one of the things that I thought always made me a very, very successful collector was that I started every conversation with a patient by asking him a question. Why were you at the hospital? I always wanted to try to identify if there were deep pockets or there were opportunities for coverage or funding that may have gone unnoticed. And so as an organization, what we have built is a capability, an analytics capability that looks at ICD-10 data and particularly focuses in on external cause codes to identify if something may have gone unnoticed. Now, what we have learned through our experience in the business is that patients present, there is a chief complaint, there's a primary diagnosis code that gets coded, but only after the patient is seen by a physician do we get the enriched information around what may have been those external causes. We then, and here are some examples, right? These are actual live examples from David's business. And we'll cover just these quickly. From a disability standpoint, this patient, the very first patient, came in with hypertension. They had chronic kidney disease, but this patient has end-stage renal disease. And so from our perspective, given our DNA as a Medicaid eligibility company, we're wondering, why doesn't this person have, why isn't this a Terry case? Why aren't they presumptively eligible for SS, for disability benefits? From a liability standpoint, patient presents with pain in the right shoulder, contusion of the right shoulder, but then later in the external cause codes, we found out that they stumbled and they struck another object. So where did this happen? Was this at Walmart? Were they at McDonald's? Did this happen at a neighbor's house? From an auto accident standpoint, you can see these other external cause codes. The workers' comp, I think, is interesting, right? So if somebody presents with pain in the left finger, overexertion from repetitive motion, but then the next external cause code, which by the way is in the 8th position for this particular account, is civilian activity done for income or pay. Now keep in mind, all of these accounts were presented to us or assigned to us as straight self-pay accounts. So what do we do with this information? We take these accounts, we tag them, and they assume their own workflow. We engage these patients around this particular potential and not necessarily around cash collections. We want to first eliminate opportunities that may exist for funding before we get into collecting money. And so our system is geared to identify these individual potential funding sources, and our communication strategies drive patients to our landing site where they are asked to really complete information around what may have happened. And if they don't engage us digitally, then we take a very, very proactive stance from our call center to reach out and try to really identify what opportunities may exist here. But as we go through the process of really moving down to collecting money from patients, what I'm presenting for you here is actual data that we've collected and analyzed since we launched the project with Jackson Hospital in December. We'll review how and when we have attempted to engage with David's patients, how they in turn have reacted to our efforts. We'll review data about how their behaviors have varied by age, generation, type of service, whether they were inpatient, outpatient, ED, how marital status impacts their payment behaviors, and also how propensity to pay scores combined with all these different factors impact their behavior. And so why is that all so important? Our goal is to test and learn from all of the data available, and for us to hone our approach so that we can maximize patient engagement and increase collections, which at the end of the day is what we all want. So let's review high-level project data and patient engagement results. In total, Jackson has placed nearly 21,000 accounts with MedAssist. We have engaged with 15,000 patients digitally, 68% of them, and I'm reading across the top of this slide, I hope you're following along and I'm not going too fast, have been engaged via SMS text messaging, 32% via email. Now to date, we've sent over 250,000 digital communications to these 15,000 patients. So just think about that for a second. That's an average of 17 messages per unique account. And keep in mind, some may have received more and others less as they've paid or opted out after one or several messages. And by the way, every message allows patients the opportunity to opt out if they wish. You're thinking about the other 5,400 accounts that we have not engaged digitally. And the reason for that is simply we did not have a mobile number or an email address, or these were patients that were Medicare self-pay accounts where we've made the decision together with David not to communicate digitally until we have a good conversation with David's MAC. We want to make sure that when cost report time comes around next year or the following year, that we don't have any surprises with respect to accounts being disqualified from the cost report. But that's something that clearly is on our agenda as a way to manage it. So how are patients engaging? 75% of patients that receive a text message have clicked through to our site. 75%. 19% of those have either made a payment or have entered into a payment plan. And so David talked earlier about robocalls and not answering the phone. I can tell you, as a guy that's run a call center for a long time, been in the business a long time, our right party rates, our right party contact rates have continued to diminish over the last few years. And most recently, at last look, we were somewhere in the mid-teens. So a 75% right party contact rate is unheard of in an outbound calling environment. The email click rates are not nearly as high, with only 23% clicking through, but interestingly, our payment rates are higher. Now, one last point I think is important. There is publicly available data that says that people that receive an SMS message actually view it and click on a link within 5 seconds. Keep that in mind as you think about people walking around in their normal day. They always have that smartphone, never too far from their reach. I know I don't. And think about how that allows us to engage with these patients and have them conduct their business. So I've created this slide sort of to demonstrate an example of how increased engagement leads to increased cash. And guys, this is a hypothetical example. I've taken basically two different views of this. I've got a traditional model on the right and a digital model on the left. Let's look at traditional first. So we start with $10 million worth of inventory. We call and talk to the right party. That means the person responsible for the debt about 20% of the time, right? This is higher than our actual rate, but we'll use an aggressive number just for the purposes of this exercise. The accounts with a total value of $2 million are then contacted. And if we collect 20%, or if 20% of that is collected from each one of those right party contacts, we're looking at a $400,000 cash value. Now let's look at the digital side of the ledger. Same $10 million, but now a 75% click-through rate. With a 20% conversion rate, that's $1.5 million. That's 3.5x. So, we can dispute or debate the conversion rates. That's all good and dandy. Probably good arguments on both sides of that conversation, but we cannot argue with the right party contact rate. 75% versus 20% is the real key here that we need to focus in on. So, aside from the fact that right party contact rates are higher because people walk around with their mobile devices, and there's studies that suggest, as I said earlier, that, people respond to them quickly. Digital engagement works when your call center doesn't work. And again, this is actual data from Jackson Hospital. Let's first focus on the two graphs on the left side of the page. First, the one labeled best time of day. And it's pretty straightforward. 77% of patients that make a payment on the site do so during normal business hours, right? 9 a.m. to 5 p.m., pretty consistent. But 23% of patients are engaging and making payments when our call center isn't open. From midnight to 8 a.m., 6%. From 6 p.m. at night to 11 p.m. at night, 17%. In total, 23% of patients engage and make a call center after hours. And interestingly, between 6 a.m. from 12 a.m. to 8 a.m., the night birds, I find that interesting. So Now that the graph on the lower, now let's focus on the graph on the lower left side of the panel that is labeled best day of the week. Now cut to the punch. 14% of payments that we received were made on a Saturday or Sunday. Again, this is the key here is, and why we went this route was to exactly provide patients with these opportunities, to allow patients to manage and conduct their personal business when it's convenient for them, using the method of engagement that they prefer, and at the end of the day, enhance and simplify their financial experience. On the right side of this slide, I'm not going to spend a whole lot of time on it, but we've broken that down based on account types. Accounts with balance after insurance, balance after Medicare, and straight self-pay. Again, looking at the best time of day, the best day of week. And here, interestingly enough, our balance after Medicare folks are early risers. 12 a.m. to 8 a.m. by far is when they conduct most of their business. So anyway, I'll move on. I think that the points for this slide have been made. Okay, I'll move quickly through the next few slides as I see that we've got to keep going here and stay on track. So how does patient age impact digital engagement and patient results? So the majority of Jackson's patients are millennials, followed closely by baby boomers. Combined, they make up about 60% of their volume. Millennials have received the most messages and have the highest click-through rate. But interestingly, they have the second lowest payment rate. While boomers click through at a significantly lower rate, but paid at twice the rate, the highest payment rate of any age group. And you can see across the bottom how Generation X and Z's reacted. Generally, younger generations click through at a higher rate than the boomers, but their payment results are not nearly as high. We then look at payment rate by financial class across generational and marital status. How do these impact the results? We studied how, again, regardless of account age, boomers outpay all other generations. We also studied how marital status impacts recoveries by financial class. And as expected, single patients, even single insured patients, lag significantly behind. Many are single parents that struggle to make ends meet. And so this is the kind of data that we use to adjust our workflow and to move these patients after a certain point in the cycle. We move them to a communication strategy that encourages them to visit the financial assistance page. And we encourage them to be screened for charity. So who are engaging and paying the most by patient type? So on the left, across the x-axis, we have emergency room. We have JIC, which is Jackson's Imaging Center. We have inpatient, outpatient, and outpatient surgeries. The results for the emergency room, as can be expected, are pretty weak, right? We collect very little money there. The click-through rates are all good. People are engaging and clicking through, but they're just not paying, versus the diagnostic center that leads the charge along with outpatient surgery in terms of recoveries. They also have very, very good click-through rates. This is the kind of data that we then provide our customer, that we go back and talk to David and we say, look, this kind of data here suggests that once these patients leave the organization, your chances of collecting diminish dramatically. And we need to ensure that at the point of service that you're doing everything that you can. And we're using this data to help train and coach our on-site personnel to do the best that they can to collect copays and deductibles and collect point of service cash. So no big surprises here, collection rates. This actually is a slide that gets more granular across all of his different service types, right? So we've got newborn, outpatient, ISU, outpatient surgery, ED, observation, among others. And again, emergency room makes up the highest volume of account, but has the lowest, one of the lowest liquidation rates. So how do patients pay and how do they behave based on propensity to pay scores? Now, David mentioned earlier that he's challenged by just the socioeconomic makeup of his patient demographics. His scores are pretty low. We use a proprietary scoring propensity to pay score that attaches a score to every account from 1 to 100 based on account attributes and patient demographic information. And so you can see that his baby boomers in the upper left-hand quadrant are averaging a score of about 59%. And this is for inpatient accounts. His Generation X, 58%, 58 on average score and 56. But look at his liquidation rates across his generational patient mix. Here we have propensity to pay by generation and account type. So we look at the different scores, but we also look at where patients are treated and how they are reacting. This is from the Diagnostic Imaging Center. Again, this is the kind of data that we provide back to David and to the customer to make sure that the people in these particular sites understand how challenging it is to collect post-discharge. And here, the same view from outpatient services, and then lastly, ED, which generally trails pretty significantly in terms of other account types. So, how do we measure this new digital journey against the historical, traditional recoveries from David's prior partnerships and processes? We went back and David provided us with data when he first ramped, or when Jackson first ramped his legacy early out process. And month one, we out-collected or outperformed his legacy AR by about 70%. Month two, 50%. Month three, 56%. And things are starting to stabilize a little bit, but we are still significantly producing at a higher rate than the traditional model. And so it's not just about collecting more, we're collecting it sooner. So there's a time value of money here that's really, really important to think about. Because again, we're talking about patients that are responding to text messages within 5 seconds. So on average, there is a quicker response and a quicker engagement with a digital process. I'm going to close with just, I know that HFMA frowns on infomercials, and I'm an HFMA guy, so I'm not going to go there. But I just do want to say a little bit about our Digital First, Digital Now campaign. So we deliver services across the RCM lifecycle. Most of you know this. A lot of you are friends and customers. Medicaid eligibility and early out receivable management services are our primary services. But over the last year, we've really embarked on this digital journey and really focused on enhancing and bringing digital capabilities to our customers and frankly to our internal operations. And what I showed you today is our solution for early out self-pay, but we've also brought digital solutions and digital capabilities to our Medicaid enrollment business, which was identified as best in class in 2019. So I might have gone through that a little quicker than I wanted to, but I'm going to throw it back to David to close. We're about 15 minutes from our timeline. So Dave, you want to close up here? We'll get to questions.
I'd be glad to. So really, summary of high-level benefits. We were able to improve our patient liability recoveries, reduction of overall bad debt expense. We ended up adopting a full call center support, and we actually are improving our patient experience. So those are the items actually that are most important to us as an organization right now, on how to move forward and what we're trying to do with our change to make that really true paradigm shift to a, for digital engagement, getting the patient first, and having them everything out in front of them. So that's all I had for now and for summary.
Sorry, Lori, we went a little quick today, so we.
No, I think we're fine. We have a few questions to go through. So David and Noel, thank you very much. Let me just remind everyone, if you have questions, please use the question and answer box. Just type it in there, and I will ask the guys. First question we have, David, for you probably: have you made MedAssist your system of record, or what is your EMR system of record?
Oh, our system of record is still Paragon. And any information or changes that need to go in there actually do upload into Paragon as our system of record.
Okay. Is there any cost to your hospital if the patient uses the digital financial assistance tool?
No, there's no additional cost.
All right. Let's see. Do you capture opting in or out of SMS messaging in compliance with TCPA requirements within MedAssist?
Yes.
Yes.
Go ahead, Dave.
No, go ahead. My answer was just yes. And then Noel can go into the
Noel will expand.
Yeah, sure. So David has a very good consent form with respect to TCPA, FCRA, consent language. But we also are bound by TCPA and rules that if a patient responds to stop in response to a text message, or responds to a email message by saying unsubscribe, those are automatically detected by the communications engine, and those are opted out automatically. Patients can also go on site, and there's actually a site for them to manage their communication preferences. They can move from text to email or email to text, or opt out entirely.
Okay. So Noel, it seems like you're answering a little bit of another question here. I'll just go ahead and ask it. If there's anything else you want to add. Are there HIPAA concerns about text messaging going to phones that are not those of the patients? And how do you verify the patient is actually going to your website?
That's a great question. So there's absolutely zero PHI on the text message. There's a bit.ly short link that allows patients to land on the site. When they land on the site, they don't have access to any PHI. They actually can only, at that point, proceed through an authentication step. Now, if they elect to make a payment as a guest, they can make a payment as a guest, but they have no access to no PHI. In order for them to authenticate, to be able to view PHI, there's a dual authentication process, and it's they have to enter their date of birth, they have to enter the last 4 digits of their social security number, and then they select whether they want to receive a one-time PIN that's good for 5 minutes via the mobile number that's on file, or a email address that's on file, or they cannot authenticate. If they then select either one of those, they'll receive a PIN, which allows them to enter it. They never leave that page. They can enter the PIN at that point and enter the full site with access to PHI.
Okay. In addition to paying past bills, can the technology link to appointments using smartphones so they can pay pre-service or on the day of service? And if so, please explain how that workflow works.
Yeah, it's another great question. So David and I have had this conversation, and we've got plans to move this capability upstream. Now, keep in mind, the capability will work anywhere, right? We receive a file from David that we load to our system, and then we begin to engage patients. So our strategy and the capability is to, at the point that a patient has been registered, they get an order from a physician, they go through the process of scheduling the patient, they do the pre-cert and authorization, and they derive a patient estimate, or we can provide them the patient estimate. We then begin to engage that patient in a pre-service arena for those days out, whether it's 14 or 5, encouraging the patient to make their payment before they arrive on site. If the patient presents at the time of service in an emergent condition and it's not a pre-scheduled condition, then we can receive either an HL7 or make an API call to our system with the copay or deductible that's due for that treatment, and we can actually begin to engage that patient while they're in the facility. Now, the side benefit of that is that in a traditional model, we're waiting 60 days or 40 days or 35 days for that claim to get adjudicated, right? Before those accounts are placed in an early out traditional setting. Here, the second that patient leaves the hospital, if they didn't pay their $250 emergency room copay, if they didn't make the payments that they were supposed to make, we can begin to engage them immediately and concurrently while their insurance claim is being adjudicated.
Okay. An average of 17 digital contacts seems a bit much. Have you gotten negative feedback from this? And can you as a hospital ask MedAssist to limit that to a lower number?
It's funny that you mentioned that. We actually have a call every day talking about COVID with our leadership team, and our CEO was talking about how COVID's affected everything, and he was like, I wasn't able to take my son into the ED to walk in with him, and then he stopped the call and goes, "And David, I promise you, I'm gonna pay my bill." He says, my son gets text and I get text. He goes, "I promise I'm gonna pay it." And I said, "Yeah, I know where you work." So it's not really. I don't think it's excessive. I don't know about limiting it. I wouldn't want to limit it. If you want it to stop, pay your bill. And actually, that's what our CFO jumped on the phone and said. He goes, "Joe, if you want the text to stop, pay your bill and they'll stop." So the whole idea of this is to continue with the text or some way of communication until the bill is paid. We provided the service, so we expect payment for that service that we've provided. So Noel, if you want to go on from there about ability to stop, you can talk about that.
Yeah, I would just say that, during implementation, we laid out for David and his team. We had a lot of conversation around what these communication strategies would look like, and those were co-developed. And so, like anything else, we embarked on that journey. We've been monitoring it closely. We have a pretty senior person that is our vice president of customer success. And her job is to monitor patient engagement, to monitor complaints, to coordinate with David's team on a weekly basis. And, if it got to the point where we needed to make an adjustment to those outbound strategies, that's something that we could certainly tailor based on the customer's requirements.
Okay. David, I'll be interested in your answer to this question. It actually is one that came up a couple of webinars ago with Andrea Mejia from Piedmont. Are propensity to pay scores really valid with the huge number of recently unemployed?
I guess, with recent unemployed, you are going to have that impact. But we're looking at the date of service. that it was. And, we are making concessions and working with patients on an individual basis for their ability to pay. So, I guess that's where I need to, lean on Noel on how what they're seeing from their technology standpoint and managing it.
It's a really fair question, and sure, it's going to impact it. But propensity to pay is but one element in our communication strategy analytics. Patient age, patient marital status, service type, whether or not they were insured, what is the average income of the houses in their, or the average income in their ZIP +4, the average home value in their ZIP +4. So really, employment is not even an element, or the presence of employment is not an element in our propensity to pay scoring. But it is a fair question.
Okay. I have 2 questions, or maybe 3 questions left here. What variables go into the ED 7% figure? Is it 7 in 100 patients or 7 copays into 100 copay? Can you explain this a little bit more?
$7 collected out of $100 assigned.
Okay.
And by the way, every number that you saw today is gross. So the way that we measure performance and the way that we present our performance is there's a dollar placed. It's how did we collect against that dollar? We don't net out recalls, adjustments, and all that good stuff. It's that way. It's consistent. It's clear, and there's no funny math.
David, question for you. How did you convince your CFO to approve your digital patient engagement strategy?
It was pretty easy because what we were previously doing wasn't working. It's old technology. I want to be on cutting edge. I want to do something different. Doing the same old thing that everyone else is doing doesn't make you a differentiator in the community. This actually had brought some talk about, how Jackson is really moving forward and changing how they're doing business. I really wanted that differentiating factor on how we're going to engage our patients and improve our overall collections. He bit quickly because, the traditional model just wasn't working anymore. And I didn't see a point in continuing with that, and neither did he.
Okay, good. All right. And Noel, for you, what's the difference between a web-based payment portal and MedAssist digital collection program? How do you charge for your technology and services?
I'm not sure I understand the question. Can you repeat that, Lori? I'm sorry.
Yeah, there are actually 2 questions. And you know what? Let me get to this one first. It just came in, and then come back to that one. David, did you look at other vendors, and why did you choose MedAssist?
We did look at other vendors. Other vendors didn't seem to be as far along as MedAssist was with some of the technology and where we were going, and it seemed to be a good fit in our space. And we talked about this is just the first step. What's going to come on after this? And so we kind of worked together as a plan to continue this type of improvement for our patient engagement. MedAssist just seemed to be a good fit. We did have communications with other vendors, but it seemed to be just one piece. We'll send text out. Well, I just don't want text. I also need the data behind it, and I want to be able to create this and move forward with it, and really enhance the growth. But be a part of how it's going to change. So that's really how we made our selection. It wasn't just one piece, this is what's in the box. It's, hey, this is what's in the box right now, but this is what we're growing to and where we're going to move to in the future. I really wanted to be a part of that.
Got it. Okay. And then Noel, back to the question I was asking you previously. What's the difference between a web-based payment portal and MedAssist digital collection program? And then the next question from the same person is, how do you charge for your technology and services? I don't know, perhaps you want to maybe try to answer that at a high level, and then I can give you this person's contact information to follow up directly.
Yeah, so the first question about, there really is no difference, right? So I guess if they're asking whether or not, we would be open to engaging folks with outbound digital communication strategies and have them land somewhere else instead of our digital, instead of our self-serve site, certainly open to that conversation. But we delivered a comprehensive solution, and our solution is a comprehensive solution. It is a series of outbound communication strategies with a self-serve site for patients to engage, with a back-end call center support where necessary, providing the traditional early out work that needs to be done if digital engagement isn't present. Our fee or our price for digital engagement is significantly lower than a traditional model. We can deliver this capability for significantly less than a wholly traditional model.
Okay, great. All right, we are just over time here, but and I know we still have quite a few people on with us, so wanted to say thank you again for joining us. Be sure to join us next week on June 17th for our next webinar. It's going to be COVID-19 Provider Response and Revenue Recovery with guest speaker Jonathan Wick of TransUnion. Please be on the lookout for regular emails from Georgia HFMA for the latest on our Wednesday webinars and other activities. Again, thanks everybody for participating today, and thank you David and Noel for sharing your expertise. Just a reminder, the presentation is posted on the Georgia HFMA website, and we'll also be posting the recording of today's session. And finally, please be on the lookout for an email from me coming probably by Friday morning with your CPE credit form, which you can then self-submit on the National HFMA website. So that wraps it up today, everybody. Thank you again for joining us. Stay safe and have a great afternoon.
Thank you.